Thanks, guys. Thanks for having me here. And really, I need to change that because saying that we've created the first harm reduction program is a little too broad. I mean, we've created the first syringe services program, but as that last presentation displayed, there's many, many ways to do harm reduction without actually handing out syringes. So just wanted to clarify. Okay, so yeah, so we basically, long story short, I'm a person in recovery, and part of my addiction brought me face to face with hepatitis C. When I was in recovery, I was fortunate to have the opportunity to get that hepatitis C treated with a beautiful new medication called Harvoni. That was about 6 years ago or so. And along that journey, started looking around as to why there weren't syringe services programs in South Carolina. So I spent about a year of time trying to research and network and figure that out. And then finally, in 2017, started actually doing syringe exchange out of the trunk of my car, which is that picture. And then 2 years ago, started an MAT program called Carolina Wellness and Recovery of Powdersville. And we do both of those services under the same roof where I'm sitting right now. All right, so I'm not going to read this whole thing to you, but this is just straight off the CDC's website as to what is harm reduction. And just some key points to take from this is that it is an evidence-based practice with nearly 30 years of research. So this is not a questionable intervention. This is not something that I think may be beneficial. This is an evidence-based practice that's been going on around the entire world for almost 4 decades now, really. Okay, so services that we provide with Challenges, Inc. We do syringe exchange, which you'll see through this talk is called a syringe services program, or an SSP. Some people call it a syringe access program. But we do actually provide sterile syringes and other safe using supplies. So that means the cookers and cotton filters, tourniquets, alcohol swabs, and many more things, condoms, feminine hygiene packs. So we provide all of those sterile using supplies, and then we also allow people to bring back the used syringes so that we can safely dispose of them. We do mobile syringe access, which is really kind of most of what we're doing now because it's taken off in several counties around the state. And that's basically just bringing those services to the people. Obviously, overdose prevention is a big part of the work we do, which involves naloxone. We give out intermuscular naloxone as well as intranasal naloxone. We give out a ton of that, and actually, since COVID, our naloxone distribution has quadrupled. So we're currently doing about 1,000 doses of naloxone every month. And it's great because we're getting it into the hands of the people who need it. We do drug checking or drug testing, which involves a fentanyl test strip so that people can test their substance, whether that's an opioid or a stimulant or a benzo, and see if there's fentanyl in what they're about to consume. We also do HIV and hepatitis C testing and referral to treatment, and we'll talk about a case involving that. And then, of course, we do medication-assisted treatment here using medications like buprenorphine and naltrexone, which is great that we have all of that under one roof. And we still try to provide this idea of detoxification for opioids, alcohol, and benzos. And we do that on an outpatient basis. Now, obviously, for the alcohol and benzos, the person needs to be appropriate to do that on an outpatient basis. They need some sort of social support at home, and there's some other protocols we put in place. But it is something we try to offer because, MAT might not work for everyone, or someone might want to try a different pathway. All right, so South Carolina by the numbers. So most of this, if not all of this information was taken off a great research, a study. Actually, you may have seen Mike Malone talk about some of this a couple weeks ago, but it was done by the Institute of Medicine and Public Health, the IMPH, and I put a link at the end of this presentation for their website. It's just imph.org, and I would encourage all of you to go check that out. There's some really good data specific to South Carolina. So South Carolina right now has the nation's 8th highest rate for new HIV diagnoses. In South Carolina, the average lifetime cost for treating one person living with HIV is close to $500,000. So that you can tell this is a huge cost to the healthcare system. For hepatitis C, the lowest cost treatment option is currently $26,000 per infection, but can be as much as $189,000. When I did my Harvoni treatment, it was about $90,000 that my insurance paid for. In South Carolina, private insurance only pays for roughly 15% of these treatments. So the large majority of HIV and hepatitis C treatment is being paid for by tax dollars, whether that's Medicaid, Medicare, or it's just for indigent funds. I always like to bring this point home that the cost of one syringe is about 9 cents, maybe 8 cents. The average IV drug user spreads hepatitis C to about 20 people. So you can see like how this can multiply and really take off in the community and become such a cost to the healthcare system. Studies show that implementation of syringe services programs can decrease HIV and hepatitis C transmission rates by 50 to 80%. So it is known globally at this rate as one of the top key interventions to reduce these transmission rates. I don't know if any of you were a part of the Hepatitis C Strategic Planning Committee last summer. That was a big national event. Also, the ending the epidemics, the HIV, that was another national program put on. And syringe services programs are right there at the top of ways to find a solution to these problems. We also talk about endocarditis, which is a heart infection. I believe it's a heart valve infection, if I'm not mistaken, and soft tissue infections like abscesses. And so syringe services programs can reduce these issues, which reduces emergency room visits. And so that's another thing that we try to work on, is reducing the amount of time someone has to go to the ER to get an abscess drained, and especially to get endocarditis treated. Endocarditis is about a 6-week treatment with a surgery, and can be very expensive. And so the treatment cost for endocarditis has increased 18-fold from 2010 to 2015 to currently about $50,000 per case. 42% of those cases are Medicaid. All right, so engagement. So there's this, anytime you talk about syringe programs, you'll hear people state this great statistic where participants of SSPs are 5 times more likely to enter into treatment and 3 times more likely to stop using drugs. So the question is why, right? We're giving people syringes. What, isn't that encouraging drug use? Aren't they going to use more drugs? How is this possible? So the next slide will show you some examples. And I'll try to go through these quick. So these were just kind of 3 testimonies that happened very recently. All of these happened in the last 2 or 3 months. And it kind of talks about this engagement piece. So I'll try to move through these fast. So number 1, female with soft tissue abscess treated with antibiotics. So this was a young lady who had an abscess right on her wrist. She was living in a nearby motel. She has been using our services a long time. And when we made a delivery to her for supplies, we saw this large abscess on her wrist. A volunteer gets a prescription for antibiotics from our physician's standing order at a local pharmacy. This is a local independent pharmacy that we deal with. We deliver the medicine along with wound care supplies to the woman in need. So like Band-Aids, gauze, antibacterial soap, a wound cleaning solution. And so 1 week later, we saw her again for supplies and her abscess was completely healed, saving the healthcare system money. I don't know what that would have cost if she went to the ER, but I'm sure it wouldn't have been cheap. She was unemployed, uninsured. And again, because of the stigma of someone like that walking into the ER, she definitely would have put it off as long as possible. And actually, when I was the volunteer in this case, but when I went to see her, she had her abscess wrapped in a sock. So not the best situation, but pretty amazing to go back and see her a week later and see this wound completely healed up. Okay, next case, man who tested positive for HIV. Okay, so a man comes into our office for services on a regular basis. Never mind. So he's been coming to us on a regular basis. One day he was asked about getting an HIV and Hep C rapid test at our office. We do testing every Monday. He stated that he already knew he was positive for hepatitis C, but he said there was no way he was positive for HIV. He was with a group of friends. They all decided to get tested, so they encouraged him to get tested anyways. Turns out he was positive for HIV. This was our first HIV positive case at our office since doing testing. The care coordinator who does the testing was able to sit with him, provide comfort, education. Obviously, that's a huge diagnosis to give someone. He was able to sit there and cry with the guy and just talk about what life is going to look like and how we can take care of him. We made a warm handoff to the HIV treatment provider, and he was able to start antiretroviral treatment the next day. 30 days later, he was undetectable of HIV. Just an amazing story because this is an individual who would not be volunteering to get tested in his normal day-to-day life. He was married. He had a wife who he was having unprotected sex with. We were able to stop that. Obviously, he's an IV drug user. We were able to give him sterile supplies and educate him on not sharing with other people. So great impact as far as the community is concerned. And then the last case here, male who transitioned from syringe services participant to medication-assisted treatment patient. This is a man who had been using our harm reduction services for almost 2 years, finally decides he wants to stop using drugs. He comes in for his syringe exchange and asks for more information on treatment options. And that type of thing happens a lot. People come here for sterile supplies and they say, hey, what's this Suboxone deal? Or what's this MAT stuff? And how does that work? So we explained that to him. We talk about the resources and his treatment options. He calls the following week to make an appointment. Now this person is on medication for opioid use disorder. And let me get this chat out of the way. And is speaking with a counselor weekly. We were able to scholarship his treatment cost for the first month, removing that financial barrier. Because we are a private practice, we at the moment don't have access to a lot of grant funding like some of the other programs. So our way of dealing with that is just basically giving people free treatment. The goal is to get this person stable and employable so that he can continue receiving treatment. Obviously, we don't want to, we have to be careful about, you have to be realistic. And if someone can't afford to come to us, we don't want to kind of set him up for failure. So if he can't afford it, it would, likely we would refer to one of the other partners in our area who are better financially fit to serve him. So anyways, just 3 examples of kind of why syringe exchange works and the benefits that come of it. So talking about naloxone, we have currently, we're up to about 12,000 doses of naloxone that we've distributed. We have reported 316 overdose reversals as of this week. That is very underreported, and anyone here who does naloxone, I'm sure, is aware of that. That's actually not a great data point to promote because it's so unreliable, I guess you could say. But, you know, nevertheless, 316 people are alive because they had that naloxone, pretty big deal. We talked about this before. Before COVID, we were doing about 250 doses a month. Since COVID, we're currently doing about 1,000 doses a month. Greenville County, as all of you know, 2018 saw almost an 80% increase in overdose. I've heard that those numbers have just gotten worse since COVID around the country. We do, you know, one key part to that for us is that it's peer-to-peer distribution. You know, people aren't, so we're removing that stigma. People aren't walking into pharmacies and other places. You know, it's active drug users just distributing it amongst themselves. And we're, you know, these are getting in the hands of IV drug users, you know, so those at most risk of overdose. This was a little program we've tried to start, and it's taken off slowly, called the Naloxone Found Here program. The idea was to target high-risk areas. Anyone here who is familiar with substance use knows that many public restrooms are common areas for drug use. I know I had my favorite gas station bathrooms and Starbucks bathrooms and whatnot where I could lock the door and be safe. So these are also big, you know, risky areas for overdose. We have partnered with a gas station chain that owns 500 gas stations across the state, and they've agreed to roll this out in all of their gas stations. That hasn't taken off yet, so it's been difficult, but we're getting there. It's going to happen. We've done a couple in the Anderson area, and we've also opened that up to just any business, any small business, or any business of whatever size, to have naloxone on their property. We will train them. We will provide the naloxone so that they have it in case of emergency. All right, so this is what our street outreach looked like 4 years ago. It was basically me and a friend hanging out at the trunk of my car. And this is what street outreach is about to look like. So one of our fabulous partners in the upstate, the Phoenix Center, has donated this little mini school bus to us. And we just got funding for insurance and all these other things. So we're not currently driving around in it yet, but it's about to happen. And so this is really cool because we currently do mobile outreach in about 6 counties across the state. But, you know, it's a little bittersweet because what's nice about the office is we can offer all these wraparound services like testing and counseling and treatment. And so when you're just doing mobile services and making deliveries, essentially, you lose a big component of this intervention of syringe exchange. And so the idea with the bus is that it's big enough to allow us to do these wraparound services. So we're going to outfit the inside of it. We're going to take out some of the bench seats and put a table and make it just kind of comfortable. Probably set up a little table outside as well. And so we'll be able to offer these outreach, these wraparound services to more rural areas or areas where people don't have transportation. Yeah, okay. Oh, I was going to say, we'll have to talk to some of you guys on the call too, because we would like to be able to do some street medicine like MAT. So if any doctors on the call want to help out, let us know. I got asked to leave this slide in by Dr. Alan Litwin, if any of you know him. This was just, I guess, to show that most law enforcement actually support this practice. This was us 4 years ago doing syringe exchange on the street, and the cops came by to check us out and see what was going on. And, you know, they fully supported us and gave us a little word of encouragement. So I don't know, it's just nice because our experience has been that most law enforcement officers believe in the work, they agree with it, and it makes sense to them. We do some mail-based syringe exchange as well, actually quite a bit of it. So we just mail whatever. We get emails and messages every week. Sometimes we just mail naloxone kits around the state, fentanyl test strips. Sometimes we do syringe supplies. That's what's in those brown paper bags. So we do a lot of mail-based syringe service work. This is Overdose Awareness Day in Greenville, South Carolina last year. It was put on, we had all sorts of partners. Favor Greenville was there. The guy holding the blowhorn on the left is a volunteer who works for us named Chris Stepp, who lost a daughter to overdose and has kind of made it his life's work to do this. It was a great event. We're going to be doing it again this year and hopefully be even bigger and better. And you know, a big part of doing this work is advocacy. And oh, you can see Tina down there in the bottom right. So there's a bunch of good local favorites in there. But you know, we've come a long way from 4 years ago. So pretty powerful. And then I just wanted to show you guys some pictures. You know, a lot of times when we hear about syringe exchange, it sounds scary and ugly. Like we're talking about needles and abscesses, and you know, this is like some underground, you know, dark thing. And I just wanted to show you what our office looks like. And that room on the left is where I'm sitting right now. That's our lobby. That's the doctor's office on the left. Our provider is a physician's assistant named Jean Chunyo. She's really great. That's another therapist office on the right. And then that's our lobby on the right-hand side. And then that little supply closet on the left is actually where the magic happens. So if that closet wasn't there, none of these other things would be happening. That is truly like the carrot at the end of the stick. That is why all of this can happen like this. It's why we're able to engage with this demographic. And so it doesn't look like anything fancy, and actually it looks a little better now than it did then, but that's why this all happens. So talking about legislation reform. So one of the biggest, most common questions we get is syringe exchange illegal in South Carolina? Well, the answer is not technically. South Carolina law does not prohibit syringe exchange, but rather there is no legislation that supports the practice and implementation of it. So unfortunately, there's this perception around the state that syringe exchange is illegal. If you ask anyone in South Carolina, they'll tell you that's the case. That's actually not true. Legislation does not, nowhere in state legislation does it mention anything about it being illegal. So what does that mean? It just means that there's no funding for these programs to exist. So that's why we really need that legislation to change so that it can open up the door to receiving all of this federal funding. And I'm sure a lot of you heard last week, I think it was like $130 million being contributed to fentanyl testing and things like that. So there's all this harm reduction money right now that South Carolina is not getting access to. So the CDC, SAMHSA, NIDA, there's all these groups right now that are willing to help us out if we can just change some legislation. So I guess, again, what does that mean? It's not illegal, it just needs support. So one of the biggest things people on this call can do, and I'll end here, is that you can speak to your legislators, your supervisors, your department heads, anyone high up in your agency, and kind of educate them on that, because I think that perception, even though it's not true, it kind of holds us back. And then there's that link, that imph.org. I just really encourage anyone to go. It's a great bipartisan study, some really great info. So I think that's all I've got. There's some references, yeah.
Thank you so much. And we know we're almost at time, but we will stay on. For those of you who can stay, we invite you to stay. We know if those have to go, that is okay, but we will stay on for some Q&A and discussion. And as a reminder, we will be back on May 7th, focused on adolescents and medication treatment for opioid use disorder. And Justine Welsh from Emory will be presenting. And I'm going to go ahead and turn it back to Dr. Hartwell.